You are listening to the Only Healthcare podcast, created to inform you on the whys, hows, and whats of healthcare. Hosted by industry leaders Michael Navin and Dr. Randy Vogenberg, discussing why cost and risk are so high and who should be held accountable. How will technological advancements merge with the quality of care? And when does the public gain access to advanced medical treatments? Listen in as Michael and Randy answer industry concerns for the public and all stakeholders involved.
Good afternoon. Thank you and welcome back to our second podcast of Only Healthcare Podcast. My name is Michael Navin, along with Randy Vogenberg. Today, we wanted to talk about the difference between coverage and reimbursement when it comes to medicine. There's a lot of nuances around coverage. In some cases, drugs are listed to be covered and shown to be covered on the formulary list, but oftentimes they're not reimbursed. And if they are reimbursed, a lot of the times it's coming from the patient. So we wanted to take a couple of minutes to really talk about how that works, the difference between coverage and reimbursement, and what that means for you, what it means for providers, what it means for pharmaceutical manufacturers, PBMs, et cetera.
Just to pick up from our previous podcast, we're going to focus on the commercial insurance landscape. We're not going to be talking about entitlement programs. And the easiest way to think about coverage is that a plan sponsor is establishing what does a road look like for access. And the way in which they do coverage, or we would call it health insurance coverage, is defined as the legal right to receive reimbursement or payment for healthcare costs. So we're really entering into some type of a contract, and the contract is with a health insurance entity. It could be a health insurance company. It could be a group health plan, which is the employers. It could also be unions. It could be municipalities that are the plan sponsor. Or it could be a government program like CMS's Medicare, which is an insurance program. So let's think about what is the legal definition of insurance coverage. So since we're talking about risk when we talk about insurance, think about insurance as a fiscal arrangement, a financial arrangement, or a contract in which one party agrees to indemnify or cover the other against a defined or predefined category of risks. And that's in an exchange for a premium. So we're starting at a high level here. As we begin to talk about, well, what does that contract actually look like? The entity that is insuring that risk may promise to financially protect the patient, in this case that we're talking about, from the cost of the claim, a damage or liability that is stemming from the treatment event, which could be receiving the prescription product, it could be receiving a medical therapy, it could be a medical procedure, and so forth. We start going down into more detail, differentiating what is coverage and policy. So we're not quite to reimbursement yet, but we're getting closer. So we're still under the coverage component. And so the typical insurance policy that we're talking about is actually a collection of coverages. So if you think about what you do with your automobile or with a home policy, it's a series of coverages. What is going to be coverage? And each coverage has a limit. So they're basically setting some financial parameters in this contract, which is the insurance. And so you can have multiple limits within one policy, as an example. So with the car insurance policy that I was referring to, you could have liability coverage, you could have collision coverage, you could have comprehensive coverage, and they each would have separate limits.
So is it fair to say that there's a gap with people understanding what their healthcare coverage is versus what an auto policy, for example? Auto policies seem to be very straightforward, to your point. Collision liability, whereas a health insurance coverage has really a multitude of steps that require patients to get covered or treated or covered for that care, right? So back to the point I'm trying to make, I think what we're saying is people really need to understand their policy to understand what coverage and reimbursement looks like. Is that accurate?
Yeah, and obviously the patient needs to understand that, but everybody who is in that event, which could be a provider, it could be a hospital, a physician, a manufacturer who's supplying a product or some other service. So everybody who's involved in that really needs to understand what does that arrangement look like? What is that policy? And understand there's legal aspects to this because you're dealing with financials around that risk, which is we would consider the claim in healthcare. So you're absolutely right. Everybody needs to understand that up front. So the classic example is today, in particular, when you try and see a physician, you don't feel good, you want to see your physician, you can't get in to see the physician. Physician's office tells you to go to the emergency room. So you go to the emergency room, and then after the fact, after you're seen, you're treated, etc., you get all these bills from the emergency room. And so that all has to go back to your policy. The policy doesn't incent you to go or want you to go to the ER. They want you to see your physician in the physician's office. So understanding some of these nuances is very important.
It's a really good point, Randy. And I think what we should do is also talk about the drug and other therapy side of this. When it comes to reimbursing a drug, they're driven by what's called formularies. And a formulary is simply a list of covered products provided by either the PBM or the insurance company that you're working with. And in that coverage, there's many different steps and many different tiers of status, for example. So being simple, a generic tier is the tier 1 formulary. A branded tier is tier 2. A non-preferred brand might be tier 3. And then you have a multitude of specialty tiers that sort of go from there, really based on the cost of those medicines. The higher the cost, typically, the higher the tier that they fall into. However, manufacturers can work with the PBM to improve that position by negotiating a rebated price for that product. And that's often how things are done in the pharmaceutical world around the reimbursement side and the positioning of your drug on a formulary so that a patient ultimately can get that product when they need it. That also drives the provider's decision making around how they may or may not prescribe a certain medicine, because there's oftentimes hoops they have to jump through, known as prior authorizations or step edits, in order to get that product. And one of those could just be simply failing a generic drug, or you failed a drug that was in the same category, but you needed to try that first before you could move on to the other drug. And those are often a lot of the challenges that are out there when it comes to understanding why can't I get something, or why can't the doctor get something for me. So in the drug side, therapy side of things, it's not as straightforward as it would seem, even if you were looking at a formulary provided to you by your employer, plan sponsor, or your PBM. And so one of the things we wanted to talk about, because it's such a hot topic right now, is the GLP-1 category. And the GLP-1 category are drugs that have been created to treat people with type 2 diabetes, but have significant weight loss benefits for those patients as well. So it's starting to see lots of growth and lots of utilization out there for those products. But interestingly enough, when you think about how those products are paid for, there's a lot of confusion. Employers are saying, wow, these drugs are really expensive. I can't afford it. How do I stop my patients from taking it, or my employees from taking it, if I can't afford it underneath the plan benefit? But at the same time, you have really good outcomes, and people are actually benefiting from these products, and they're ultimately driving down their long-term costs, such as hospitalizations or even complications with diabetes. So you have to balance those two. But at the end of the day, when you think of the actual cost, how that cost gets paid for, it's highly paid for by the patient and the plan sponsor. Very little of that payment is coming from the PBM, who's supposed to be the insuring, covering entity at the end of the day.
They're not insuring anything. A PBM does no insurance.
Well, but they're charging a premium to the plan.
They're making a payment on behalf of the plan sponsor.
Right.
Okay. So you got to be careful about that, because the PBM will tell you they take no risk and they do nothing with insurance. They're an administrator. So that gets back to the whole issue of contracts.
No, it's a good point. But I think that's a good debate, because I think they get paid and act like an insurer. But to your point, if they're saying they're not taking risk,
right,
then what are they?
Exactly. And they are a third party administrator is what they are. And that gets back to, you're talking about making a payment to some kind of a healthcare provider, whether it's a physician or a pharmacy. And so you look back to the original policy and the contract that is established around the healthcare insurance and coverage. Now we're talking about, well, what does that road look like with guardrails and other safety and risk mitigation kinds of stuff that's put in there after the fact, which is this third party administrator. That's really what we're talking about now. So what we're really doing is saying, there, because of that initial contract, and you're contracting with a third party administrator, in this case, a PBM, in the example that we're talking about with GLP-1, that there's a payment being made on behalf of the plan sponsor. And there are going to be some rules that go along with that around that payment. And it could be different to the physician, it could be different to the pharmacy, and it could be different to the patient. And so there's a contract that's happening in multiple directions beyond what the plan sponsor might see. And this is where a lot of the misalignment happens and the disconnects occur. And nobody really understands who's paying for what is ultimately a big part of the problem.
That's a good point.
So you have an amount that's billed based upon the service or the product, and then the amount agreed upon by the third-party administrator or the employer health insurer, or it could be PBM and CMS. So you got all these entities that there are all these different agreements with around payments, all based around the same claim. And there's also potential margins or additional profit that's in there beyond just the payments for the services themselves. Going back to kind of contract language, when we look at reimbursement, it always involves a fixed amount of money per the individual covered life, and it's paid in advance in some cases for an agreed set of services. If it's medical, that's very common, over a certain period of time. That amount is determined by the range of services that are actually being provided. If we're talking about the medical side, it'd be the same thing on the pharmacy side in terms of the prescription claims that come in for that individual person. So that's part of the reason why we look at what's the quantity of pills or injections that you're getting as a patient, is because there's going to be a certain amount of cost that will be allowed within a given plan year. And that's where that comes in. So there are rules around that as well in terms of what the maximum would be, just like the deductible would be, what you have to pay as a patient up front versus what is covered by the plan itself, or as it's some kind of a discounted contract arrangement with the provider. So there's a lot of different rules that come into play on any particular reimbursement claim. And that's part of where the confusion comes in, to try and, like peeling an onion, figure out, so who's paying for what.
So it's not a disagreement I would have with you, but the patient's paying a premium. That premium is inclusive of pharmacy benefit, which is technically an insured product on their if you want to go back to the policy, we can read the policies. So there is an entity that's taking on that risk, whether that's the plan sponsor, a stop loss carrier, a PBM, a plan. There's somebody's taking something, but the individual has to pay that premium every month with the expectation that they're getting something in return. And when they actually look at the numbers, in a lot of these cases, they're not getting anything in return. They're actually paying more to have access to medicines or treatment or provider services. And then where does that money go that they're spending to have access to these products and services?
And I think that's part of the understanding that has to be made by all parties as to what is their role, what are they doing. In terms of the risk, which is the basis for insurance, and the financial responsibility, that's all set out in the contract language. So from an insurance perspective, to your point, the only risk or the insurance piece lies with that. Who is the plan itself? So in this case, it could be an employer, could be a health insurance company, etc. And then if there is a form of stop loss or reinsurance, then they would have some risk that they could be exposed to. Everybody else through the contracts is about managing that risk. They're not taking the risk. And that's the big difference, except if they're in some type of a risk reward contract arrangement, which is sometimes common with hospitals and with medical groups, where you could have some limits to exposure, as an example. But that would be specified again in the language. So if you're a manufacturer and you're working with a third party around better placement, which is what you were talking about earlier, you have to be aware that there are other contracts in play and other risk reward scenarios that are also in play that you may not be aware of. And that's the same problem on the employer side. So the employer and the manufacturer are the two that are biggest risk when you start looking at what's happening in this insurance ecosystem.
Right. So it's really the bridging of the employer / plan sponsor and the providers, whether that's hospitals, physicians, manufacturers of goods and services, that's being gapped by the PBM or the insurance company.
So you can have on the medical side a third-party administrator who does all the claims processing, claims administration that a PBM does on the pharmacy side. And a TPA, a third-party administrator, could also subcontract to a PBM to provide the drug portion of that health benefit scenario. So it can get even more complicated as you go through this. So it's all about really making sure everybody understands what's really going on and that you're using the services at the right place at the right time for the right reasons.
In your opinion, how does that best get communicated to people that don't have that level of insight, right? How do we create awareness?
Yeah, so ideally they would know it in advance in some way. So it could be through various tools, either information that's shared from the health plan or the third-party administrator, PBM, and so forth, and other IT tools that are out there. There's lots of apps out there now.
I see as this has gone on and on, I make more of an argument that the manufacturers should be working directly with the patients and obviously through the providers, but on the financial side, providing direct pricing, because at the end of the day, the patients are picking up most of this anyway, whether that's through a premium they pay every month, whether that's through a deductible, whether that's through copay responsibilities. The last 20 plus years, there's been such a shift back onto the consumer, and they just don't have good pieces of information to let them understand what it is and understand what the drugs should cost, because there's so much going on in between with the PBM and the manufacturers. So it's ideal that there's definitely, resources that patients can have at their fingertips.
Yeah, and the ideal that everybody talks about is the last step is at the point of sale. So if you don't do it in advance, you want something to happen at the point of sale. And that's in particular where you see a lot of the advertisements these days, and a lot of the new technology is aimed at you could be looking up this information anytime, anywhere, including when you're standing at a pharmacy counter. Did I really get the best deal based upon my benefit coverage? Or if I'm paying cash, am I getting the lowest possible cash price as well? So
Right.
to your point, there's a lot of opportunity for consumers to be better consumers and have more education so they can make a better decision.
Yeah, and if they're not, because there's really nobody else looking out for them. If the PBM's not going to look out for them, the manufacturer doesn't know who they are until they get the prescription or enroll in some kind of a patient services program. So it's really incumbent upon, I'd say, the employer, because they're obviously part of the financial responsibility, and the patient to be able to have tools and resources to get them what they need, or at least get them the knowledge that they need to make a decision. And you made a point about point of sale. There's also the argument to say, how do I know before I go? How do I get this information before the doctor prescribes me this medicine? So that, yes, number one, he's prescribing me or she's prescribing me the medicine that I need for my condition. But secondly, what's the financial component before they actually send that in? And that saves a lot of time and error as well.
Yeah, the employer as a plan sponsor or app trying to get more patient engagement, as they call it, around these decisions, the more you can do in advance, the better. Absolutely. And to interact with whoever is responsible, if it's a PBM or a third party administrator that you as a patient would call, that's on your coverage card, as an example, because they know what's covered, what's not covered, where it's covered, et cetera, et cetera. On the drug side, it's been a little more complicated, where you probably have to work with a PBM, but that doesn't necessarily give you the best or lowest cost.
Right.
So that's been the big challenge of late, particularly as the claim costs on these prescriptions have gone up dramatically. Historically, the rule of thumb has been that a plan sponsor, whether it's medical or pharmacy, is probably paying around 80% of the total cost of the claim. The problem is, well, what's really the cost of the claim, the true cost of the claim? And nobody really knows that either. We have more questions than answers, and that's been part of the challenge in the marketplace amongst all the players. How do we do a better job of ensuring that the right patient at the right time is getting the right medication, but now also at the right cost?
Yeah, and I think from our perspective, we have a technology known as Peak. So it's a shameless plug for our Peak Meds technology, but that does integrate all of those services into one. There are many others that do it, but not necessarily integrate all of that pricing into one. But there's certainly other things out there. People have used GoodRx and things like that to find out their pricing. But as technology continues to advance, and as PBMs are more accountable to provide machine readable files around net cost for these medicines, there'll be more technology advancements, I'm sure, that patients can use, just like Peak.
Yeah, I think the key takeaway here is that when we talk about reimbursement around coverage, you have to really understand, well, what is the perspective that you're trying to ask that question from? So if you're a patient, it may be all the same questions, but there may be different answers. Same thing for a plan sponsor, same thing for a manufacturer. When you look at the PBM and what they're doing or not doing, that's another whole set of questions.
Yep.
So you do want to know in advance as best you can, and you want to get the information before you start paying out the money. Particularly, typical coverages start out with a deductible on the beginning of the year for the plan. So you want to make sure that everything that you're spending at the patient level is counted as appropriate against your deductible so that you're not paying more out of pocket as well.
Yep.
So there's a lot of components to this, for sure.
So I think it's been a great discussion. We continue to evolve this conversation. And I think one of the things that rises to the top here is the fact that there has to be better communication between the employers and the manufacturers.
Absolutely, because it's gotten out of control.
Thanks everybody for joining us and participating. And please, again, provide any comments, questions, any recommendations around topics. We'd love that. So let us know.